Hi, good morning, good afternoon, good evening. Thank you for joining the webinar. My name is Dr. Heather White. I am the Executive Director for Together for Health. I'm pleased to welcome you all to the next installment in Together's ongoing webinar series, which highlights important topic areas in global cervical cancer prevention and control. On behalf of the Together team, I'm very happy to welcome our colleagues today from Jphiego, Botswana, who will share their experience as Together's 2019 Cervical Cancer Grants Program recipients and their work in conducting a demonstration program to incorporate thermal ablation treatment into their SRH programming. In addition, we're happy to welcome our colleagues from the Botswana Ministry of Health and Wellness, who will share their vision for increasing access to these new technologies to improve early detection and treatment for cervical cancer and their broader vision for national cancer control. Following our presentations today, we will open up the floor for questions, and I encourage you all to share your questions with this group. Before we begin, just a few words on logistics. First, all attendees are on mute. Following the presentation, we will have roughly 15 minutes for a Q&A period, and I will moderate the session. If you have a question for our presenters, please do write the question in the Q&A box, and we will do our best to get to all of them. If not, we will try to follow up directly following the webinar. The webinar is being recorded and will be available on our website after the event. If you'd like to see the catalog of this or our other webinars, please visit our website at togetherforhealth.org. And finally, we'd love to hear from you about other topics that you may be interested in. At the end of our presentation, we will post links on how you can get on Together's mailing list and contact us directly. Great, let's get started. To begin, I'm going to share some details on our Cervical Cancer Grants Program. Together launched the program in 2019 with the aim to provide small, highly targeted grants to programs to generate the evidence needed to speed access and uptake of cervical cancer prevention technologies in low and middle income countries. Next slide. Together's team offered two $25,000 awards for one-year programs. I'm very happy to report that it was a very successful and competitive call for proposals. Together had a total of 26 applicants from across 20 countries who submitted applications for the Small Grants Award. Grants submitted included themes on improving HPV vaccination distribution, as well as grants related to enhanced visual assessment during screening, self-sampling, and loop electrosurgical procedures. Next slide. Our 2019 grantees, of course, included our colleagues from Botswana. Jphiego's work, which we'll hear in much more detail momentarily, included a thermal ablation project to be implemented at 4 high-volume health facilities in the Gaborone district. Also looking at the feasibility and acceptability of thermal ablation treatment among both health providers and their clients, and to inform the national effort for integration and expansion of thermal ablation throughout Botswana. Next slide. Our other grantee was Movi Cancer Foundation from Nicaragua. They also submitted an application to implement thermal ablation training in 3 of their regions to evaluate the procedure's impact on treatment, as well as its feasibility and acceptability among their health providers and clients, and also to incorporate systemic training and development of guidelines and protocols for the use of thermal ablation. Their results throughout their grant period included training 10 health providers and equipping them with thermal ablation devices. And to date, they've treated roughly 25,000 eligible women for precancerous lesions. And we're hoping to invite our colleagues from Movi Cancer on to a Spanish-speaking webinar in the near future to speak more specifically about their achievements through their grants program. Next slide. So that's it for me, just a bit of background. I will say that we have been very pleased to be able to offer this first cycle of cervical cancer grants, and we look forward to doing the same in the future. Please do sign up for our mailing list so you can keep up to date on our small grants program, as well as other activities conducted by our teams and those of our core partners. And with that, I am very pleased to introduce our colleagues from Jphiego. First, I would like to welcome Dr. Amon Marwiro, who is a Senior Technical Advisor and Country Program Manager at Jphiego, Botswana, based in Gaborone. Dr. Marwiro will provide details today on the epidemiological context of HPV and cervical cancer in Botswana and share insights and lessons regarding their pilot program for thermal ablation, which was completed in October of last year. Dr. Marwiro is a public health practitioner with more than 17 years of clinical and public health experience in Zimbabwe and Botswana. He has been with Jphiego Botswana for 8 years and is the Senior Technical Advisor and Country Program Manager, leading Jphiego's efforts in HIV prevention, care, and treatment, strengthening HIV laboratory services, and breast and cervical cancer prevention and early diagnosis. Prior to joining Jphiego, Dr. Marwiro worked in government services, private sector, and with other international organizations, such as Médecins Sans Frontières. He actively participates in various Ministry of Health and Wellness technical working groups. Dr. Marwiro holds an MB-CHB degree from the University of Zimbabwe, a diploma in HIV management from the College of Medicine South Africa, and an MPH from the University of Zimbabwe, and an MBA from the United Kingdom. And with that, very pleased to hand it over to you, Dr. Marwiro. Amon, can you hear us?
Present.
Perfect.
Good afternoon, good morning, everyone. Can you hear me?
We can, just fine.
So I'm going to present the work that we did with our Ministry of Health in Botswana in introducing thermal ablation. First, I will give just the context of the country and the project where thermal ablation was introduced. Then I will go into an overview of how we introduced thermal ablation. Next slide, please. So Botswana is a small country with a population of 2.3 million and very high HIV prevalence in the general population. In adult females, it can be as high as 27.4%. Cervical cancer is the leading cause of cancer-related deaths among women. It's not surprising in high HIV prevalence. There is no data on the prevalence of HPV prevalence in the general population, but from a demonstration study that we did in between 2017 and 2018, it shows that there is a very high co-infection of HIV and HPV with as high as 40% of women between 30 and 49 years having HPV and HIV. The country has started on rolling out HPV vaccination to young girls. And currently the screening and treatment options for precancerous lesion, which includes pap smear, which was one of the eldest method that was, started in Botswana. And we also have scaled up visual inspection with acetic acid. We introduced HPV DNA testing in 2017, starting with a demonstration project. And now we are at the level of scaling up. When it comes to treatment, we use cryotherapy for smaller lesions and lip. And because of with the TogetHER funding, we also introduced thermal ablation. Next slide, please. So Jphiego started to support Ministry of Health on the National Cervical Cancer Program in 2015 with funding from CDC. And the mandate that we have was basically to support Ministry of Health to support scaling up prevention services, building capacity to the national program, and also sustainability planning. So we worked closely with Ministry of Health from project design, planning, implementation, and also data collection and performance reviews. That helped us to transfer skills and also to capacity build. So between 2015 and 2020, we have been supporting the scale up of prevention services, which includes screening with visual inspection with acetic acid and treatment, which included cryotherapy and lip. We also trained providers and also TOT as part of sustainability planning. We developed M&E framework, data collection tools, and also reporting tools. We introduced HPV DNA testing through the acceptability and feasibility. And then from there, we moved on to scaling up. In 2019 and 2020, we also introduced thermal ablation, which we partners with TogetHER. Next slide, please. So this was a rapid expansion from 2015 to 2019. As you can see from the graph there, rapid rise in the number of people that were being screened. This was a combination of expanding in terms of the actual number of sites and also increase in the geographical areas that were being covered, and also the number of people that were screened even at the existing facilities. Next slide. During the course of this rapid scale up, we encountered some challenges. Some of them were related to the technology that we had there, which was cryotherapy. We had a frequent breakdown of equipment. The gases that we're using there for cryotherapy, the nitrous gas, were very heavy, and it was very inconvenient to transport to provide services for in mobile services. That resulted in low treatment rates, which posed a threat to our single visit approach, where we needed to treat women with precancerous lesion the same day we see the lesion, and therefore we introduced thermal ablation. Next slide, please. So this is basically illustrate the effect that some of the challenges that we have to the same day treatment. As you can see from the flow diagram, the total number of people that were screened here, over 60,000, the majority of them being via negative or negative for precancerous lesion, but we had 8% that were had lesions that needed treatment. Some of them were large lesions, just over 2,000, which constituted 44%, and 56% of the clients that were screened positive had smaller lesions, which were eligible for ablative therapy. Unfortunately, only 69% of those could be treated on the same day because of a number of reasons. Some of them wanted to go and think, but we have also noted a number of times where services could not be offered because of unavailability of breakdown of equipment. So that was one of the challenges that we needed to address. And the 69% fall far off the WHO recommendation of 90%. Next slide, please. Some might not be familiar with the different techniques of thermoablation treatment. We have cryotherapy and thermoablation. The difference there is cryotherapy, you just use cold or freezing to destroy the precancerous lesion, while thermoablation uses heat to destroy the lesion. So you can see from the diagram there, there's a probe. So you would take the probe and put it on the lesion and wait for a few seconds and then remove, and that would be it for thermoablation. Next slide, please. So I'm going to take you through the process that we followed to introduce thermoablation. Next. So this is our journey. Since 2017, we had thermoablation having been included in the National Cervical Cancer Prevention Strategy. Then we started together with Ministry of Health to engage different stakeholders, including TogetHER, to find opportunities on how we can introduce thermoablation. And we were fortunate enough to get the funding. And as we were, consulting with different stakeholders in country, the first thought there was to introduce as a pilot study, since this was not yet recommended by WHO as for public health use. But fortunately, in that process, we had WHO releasing their recommendations, their guidelines that was recommending thermoablation as one of the treatment options. And from there, we changed our strategy from a study-based to actually phased implementation, starting with the pilot in 4 facilities. And we introduced trained providers. And now we are at adoption stage. Next slide, please. So we followed a smart advocacy approach, which had basically 3 phases. The first phase was to decide who to involve and set clear change objectives and identify the decision maker. We also identify the messenger who is with us today. You would hear from your presentation later on. She's very engaged and focused and very trusted in Ministry of Health. It was very easy for us to get to the decision makers because of here. She was a very key messenger to the change agenda for introducing thermoablation. From there, we developed a plan, set benchmarks for success and implementation that we are going to share just now. Next slide, please. So some of the outcomes of our advocacy was basically the National Cervical Cancer Prevention Program adopted thermoablation as part of the treatment options. And we have updated national guidelines now that have included thermoablation. We have updated data collection tools and reporting tools to include thermoablation. We had service provision at the 4 sites, and we had buy-in from CDC, which procured 39 machines. Right now, the country is in the process of training more providers to be able to scale up thermoablation to other sites. Next slide, please. So this is what we found, I think, during the period of implementation. During the period of implementation in the 4 sites, 188 people were screened during that time. I have to say this was implemented during the COVID era, so the numbers are much less than what we were, anticipating. And of those 70 were eligible for LEAP, while 118 were eligible for treatment with thermal ablation or cryotherapy, which were the two methods that we had. And 51 were treated with thermal ablation, while 35 were treated with cryotherapy. Next slide, during the period of implementation. Next slide. And then we have one facility that managed to treat most of the patients that were treated were coming from Tamaka, and also Tamaka managed to have and provide services as an outreach facility to other facilities. Next slide. So some of the challenges that we basically encountered, the procurement got delayed in the project, and we started providing services a bit late. And also this was during the COVID-19 pandemic. At the end of the day, we treated fewer clients than what we anticipated. We also had to modify activities to be able to complete our deliverables. We are happy to say we had very strong leadership and influential people at NCCP that helped really to champion this initiative. We also had on-site training. Initially, when we started, we were planning to have this as a off-site training, but because of COVID, we have to quickly change to have on-site training. It was a 2-day training, and we would have at most 4 participants at a site in line with COVID-19 guidelines. We got very positive feedback from providers and clients, but we still feel there's need for continued monitoring of equipment performance over time, since the implementation period was very short, and we are working with Ministry of Health to continue to monitor the performance of this machine over time. We also learned that this small grant managed to play a very key catalytic role in the introduction of thermal ablation, and we managed to host meetings. We procured 4 thermal ablation machines, and we also managed to support training and mentoring of providers. And with this, in the context of a bigger project, we saw buy-in from the donor, and we were able to scale beyond this project. Next slide. That's all we have. We greatly appreciate Ministry of Health, who are with us now, who championed this initiative, and we are very thankful to TogetHER for the opportunity. Thank you.
Thank you so much, Dr. Amon. A really great presentation, and we appreciate your sharing your experience. If those of you on the line have questions for Dr. Amon, you're very welcome to put them in the Q&A box, and we'll get to them following our presentations today. Next, I'm very pleased to welcome our next speaker. She's the cervical cancer champion, for which Amon was just alluding to, Mrs. Molly Rammipi, the National Cervical Cancer Prevention Coordinator from Botswana's Ministry of Health and Wellness. In this role, she actively contributes to the development of national policies and works to strengthen the M&E component of Botswana's National Cervical Cancer Prevention Program, or NCCPP, and provides mentoring and clinical support in conducting continuous facility readiness assessments and data verification for improved data quality. Molly has extensive experience in sexual and reproductive health and HIV. She has organized and facilitated numerous workshops for lecturers, doctors, pharmacy, and laboratory technicians, and also trained trainers of trainers at district health level on family planning and sexual reproductive health. She continues to develop policy guidelines, training manuals, and other materials for SRH programs for public education. And with that, I welcome Molly Rammipi from the Botswana Ministry of Health and Wellness.
Thank you, Heather. Good morning, good afternoon, good evening. It's an honor and a privilege for us as Ministry of Health to be offered this opportunity by TogetHER to share our experience with the control and prevention of cervical cancer. Next slide. My presentation will cover the three components as projected on the slide. Next slide. Next slide. Just as a background, I want to highlight the GlobalCan report of 2018 that has indicated that 9 out of 2 new cervical cancer cases occur in low middle income countries where there is limited access to vaccinations. And it is indicated that the cases are expected to worsen by 2030 if appropriate measures are not taken to prevent the burden of cervical cancer in low middle income countries. And further, the report has indicated that women with HIV are 5 times more likely to develop cervical cancer than their HIV negative counterparts. And I think my colleague, Dr. Amon, has clearly indicated that and emphasized that Botswana has a high prevalence of HIV among the 30 to 49-year-olds. Next slide. Zeroing in home from the cancer registry of 2017, there is an indication that 23,544 cancers were diagnosed, and over 1,400 cancers are diagnosed per year as recorded in the registry for the Ministry of Health, and 70% of these cancers are diagnosed late. Next slide. Further, the cancer registry has projected or has outlined 3 categories looking at the 10 top cancers. Cervical cancer has come up second after Kaposi. And then going to the top 10 female cancers, cervical cancer is the leading cause according to the report. And for the mortalities, looking at all the cancers, cervical cancer was the leading cause from that report. So as Dr. Amon indicated in his presentation, clearly there is a high burden of cervical cancer in Botswana. Next slide. Why then do we have to strengthen cervical cancer screening services in Botswana? And I think I can never emphasize much that it is due to the fact that there's a high burden of cervical cancer, which is the leading cause of morbidity and mortality among women. And we also had challenges with the cytology and treatment backlog in our country, and also challenges with screening coverage and access to screening coverage, screening services. Next slide. So what has been our achievement since we started implementing measures to curb the burden of disease? Next slide. We have gone through several milestones. I would just pick a few because others my colleague had addressed in our presentation. So I just want to emphasize on 2004 to 2009 milestone, where we were basically as a country providing screening through pap smears, which is the cytology screening modality. And our strategy, which was the initial strategy, was focusing on cytology screening using pap smears. And thereafter, in 2009, to date, we introduced the see and treat screening modality. So the rest of the milestones Dr. Amon has covered, and I will skip that. Next slide. So this is the algorithm for the past history where we were providing screening only through cytology. So the specimens were collected, and following the results, the client was taken through colposcopy for those who were positive, and then through treatment through cold coronization. And this had its challenges that have been highlighted in the previous presentation. Next slide. So these were the challenges that we experienced with the cytology screening modality that we were using from 2004 to 2009 before we introduced our VIA. So we had lots of loss to follow up, right from the specimen collection up to treatment. The waiting period was just unbearable. And therefore, introducing VIA was quite a blessing in that women were screened and treated on the same day rather than to be waiting for the results and then being booked for assessment through biopsy and then move on to treatment. So with the current state from PEP results, they go directly to our LIP clinics for treatment by our medical doctors who have been trained to do the treatment rather than to be booked to be seen by specialists. And that has really cut down on the waiting period as seen in the previous strategy where we were only screening with pap smears. Next slide. So moving on, this is our milestone for primary prevention. We introduced the primary prevention, that is the HPV vaccine, in 2013, where we started with a demonstration project that was further expanded in 2014 to more districts as a phase 2 rollout, and then ultimately the national rollout in 2015. So this was a school-based program. Next slide. So these are our achievements in primary prevention from 2015 to 2019. As you can see on that graph, 2015, our coverages were soaring high beyond 90%, and for both the first and the second dose. Even through 2016 and 2017, we were still, our coverages were clearly above 70%. And then in 2018, we had challenges with the availability of HPV vaccine. And in 2019, we had another campaign where we continued to do very well in terms of our coverages, which were above 80%. Next slide. This is a map that is showing our various see and treat services across the country. The color is not very good, but as you look at the key, we have facilities that are providing via and lip services. We have those that are providing via only, and those that are providing lip only. And then we have those that have recently introduced thermal ablation, and we have those that are started with HPV screening, which has been scaled up to more facilities. As you can see, it's mostly concentrated in the southern part of the region. That is where we did the pilot and we started the phase 1 rollout. Next slide. So these are our achievements over a period from 2012 to 2021. And what I want to draw your attention to in this achievement slide is the last block where we have 2020, 2021, because that is where we started the introduction of thermal ablation. We piloted last year and we have been scaling it up to more districts and more facilities in 2021. And we have already covered about 8 districts in our rollout for thermal ablation. Next slide. So this is our team of trainers and the providers. So we just wanted you to appreciate how big the group is per session of training. And we have support from Jphiego. You can see the specialist there, Dr. Veronica from Jphiego head office. And then the rest are Botswana, who are supporting this program from national level to facility level. Next slide. This is a slide that is showing our achievements still from 2015 to 2020. Our target was 216,968. Those were women 30 to 49 who were to be screened using VIA and PEP and PEP as well as HPV. And we managed to screen 123,845. That is accounting to 57% of our screening coverage. And like I said, this was through 3 methods of screening, PEP smear taking the lead, followed by VIA, and lastly, HPV. Next slide. So this, Dr. Amon has already shared, I will skip it. It's just to indicate the increase in the new screenings. Next slide. Our challenges, Dr. Amon has also covered quite well, except that I need maybe to focus on the primary prevention challenge, the unavailability of HPV vaccines globally, which also affected us as a country. And for secondary screening, those are the issues that Dr. Amon raised. I will not go into those, but then I will also focus on the challenges for the lab, cytology and histology specimens with the treatment through LEAP. It tended to increase the specimen, the histopathology specimens, and reduced cytology specimens, because now the VIA is catching up on cytology. Initially, the proportions were 40, 60, but now we are almost at 30, 70 as we continue to expand VIA screening services. So we are getting less of cytology specimens and an increase in histopathology. And due to lack of capacity at the lab, we tend to have a backlog of specimens, which delays transition to treatment and to linkage with oncology. And with equipment, that has been addressed by Dr. Amon. And then for MNE, we have challenges with the multiple data collection tools, but with the assistance of Jphiego, we have moved to a data collection tool, which is which we are piloting, and this will be a system that draws data right from the service delivery point. And lastly, we have challenges with fewer trained nurses and our doctors, where we continue to conduct training for thermal ablation and LIP and VIA. Next slide. This is one of the challenges that we have experienced since last year. As you can see, there is quite a dive in our screenings. We were doing quite well from 2017 to 2018 to 2019, but with the advent of COVID, we had challenges with the screenings. This was mainly due to the lockdowns and women not turning up for screenings at our facilities, and the lack of the conducting of campaigns that we used to do to reach out to more women for screening. Next slide. This takes us to the next steps. Next slide. As a country, we have embraced the WHO recommendation to move towards cervical cancer elimination. And we are basically looking at the conceptual framework that has highlighted the main components or the main initiatives that could drastically eliminate cervical cancer. And this is to do with the vaccination as well as intensive screening. So as you can see on that graph, with intensive vaccination, we can be able to reach the target of 4 cases of cervical cancer per 100,000. And with very intensive screening and vaccination, we can even go below the target by 2021. So we have embraced this initiative as the country, and we have even contributed to the launching of the cervical cancer elimination strategy late last year. Next slide. So these are the targets that we have embraced as a country, the 90-70-90 that we will be embarking on to be able to eliminate cervical cancer as a country. Next slide. These were our targets for expansion of VIA services, cryo and thermal ablative treatment, as well as LIP. So our targets were, if you look at the 2020 and 2020 year, we were intending to have established 57 sites, and we only managed to establish 52. And for the LIPs, we went beyond our target of 35 to establish 48 LIP sites. And the total, we went beyond our target for establishing 92 sites by the end of 2020. And by the end of 2021, we want to have reached at least 60 sites having thermal ablative treatment with VIA, 58 LIP sites. Next slide. So this is our future, moving towards cervical cancer elimination. We will still be screening through PEP because for some of the women who are postmenopausal, VIA might not be the best method for screening. So we will still continue to be screening through PEP. But like I said, from PEP, they will be going to LIP for treatment rather than going through the longer route of having to be seen by the specialist. And then visual inspection, we will also strengthen HPV DNA testing, adhering to WHO recommendation. And our treatment will be mainly through thermal ablation as we are trying to phase out the cryoguns with their challenges. But there will still be some facilities that are treating with cryotherapy. Next slide. So what will be our priorities for support, looking at the vision of Botswana moving towards cervical cancer elimination? We continue to embark on expansion of HPV screening and testing, and this requires a lot of finances to procure the commodities, which are a bit on the expensive side when we use the GeneXpert platform. And then we also continue to expand VIA facilities. These are platforms that are used for visual assessment following HPV tests that are positive. And as I indicated, for 2018, we didn't have our campaigns due to unavailability of vaccines. We continue to look forward to support to ensure that our girls get their vaccines at the right time, both doses. And lastly, we also need to harness or leverage on other programs to do away with missed opportunities for screening women. And this is the interaction between HIV programs, family planning, as well as breast health. Next slide. In conclusion, all we are saying is together we can prevent cervical cancer. The grants from Together for Health can take us a long way in establishing centers with thermal ablation and with treatment that is given on the same day. We can move towards elimination before the 2021 target. So let's hold hands, donors out there. We are looking forward to your support, and together we can make it. We can eliminate cervical cancer. Next slide. Thank you for your attention.
Thank you, Molly, so much. What a fantastic presentation. I really appreciate hearing from you both, and, you know, just reflecting on what is obviously such a close collaboration between your two institutions and how important it is to have very clear vision and objectives that you can strive for together as civil society champions as well as ministry visionaries. So thank you both, and hats off to you both. Now we'll move to the Q&A session of the webinar. We've got a few questions coming in from folks, and I'll just read these out. Let's see, we have, it looks like, Amon, I know that you've been answering some questions that have come through around specific elements of the HPV testing pilot. I wonder if you could just share with folks very briefly a high level of detail around the HPV DNA testing pilot that has been conducted there, what testing platform you all used, and any reflections on successes, challenges, and how you all see moving moving towards HPV testing more broadly. If I could maybe first ask Amon to share any thoughts on that, and Molly, please feel free to add. Dr. Amon, can you hear me?
Can you hear me now?
Yes, we can.
Yes. So during the demonstration project, we used Gene Expert platform, and we wanted to use the point of care or near point of care. But right now, during the scale up, we have, I think, a number of lessons that we have learned, and we can't really rely on one platform. So we are exploring other platforms as well as we try to cover the whole country. I also have Molly here and other colleagues from Ministry of Health and also from Jphiego. So if there's any additions, please feel free to add and respond to some of the questions. Thank you.
Great, thank you. I don't know, Molly, if you want to add any perspectives from Ministry of Health around HPV testing, maybe what you see as opportunities as you move towards the 2030 targets for elimination, what opportunities you may see for coordination with your other programs. I'm thinking of HIV, TB programs, or even COVID testing, which would use many of the same testing platforms. Would you like to comment on that?
Yeah, thank you, Heather, and thank you, Amon, for highlighting that challenge, because that is the main challenge. That is the main lesson that we have learned from the pilot, mainly due to the breakdown of Gene Expert and the delayed maintenance. And therefore, we approached the National Health Lab for the Ministry of Health to provide us with other platforms for the expansion. And we did a mapping for other platforms in other districts. And as we were to start rolling out to those platforms, we were hard hit by COVID. And therefore the capacity that was needed to run COVID tests needed all those platforms that we were earmarking for the HPV. And therefore that slowed down our rollout to more districts. Hence, we are still only in 2 districts, as you saw on the slide, that the yellow stars are only on the southern part and only in 2 districts. So we are not yet sure as to when we will be able to use other platforms to increase our uptake of HPV, but negotiations are still ongoing because COVID is here and other health issues are here. We need to see how best we can leverage to be able to curb both if we can use the same platforms. Thank you, Hida.
Great. Thank you, Molly. Much appreciated to you both. I have just a question for you, Dr. Amon, regarding one of our participants, Joyce Majongosi, I hope I've pronounced that correctly, asked specifically about how have you been providing services on outreach to reach more women? And of course, COVID, I'm quite sure, has constrained your efforts in that regard. But I wonder if you could speak a bit about demand creation and what kinds of messages you all are able to share with women, both women that would be coming in, women living with HIV or coming into your PEPFAR or other clinics, but also for the general population of women. Could you just speak a bit about what your experience has been in creating messaging for women and girls, if you would like to share some insights around how you have generated demand for a really impressive HPV vaccine coverage rates. I would love to hear your thoughts on that. I'll ask you, Dr. Amon, to start.
Thank you, Heather. So when it comes to, I think, communicating and creating awareness at facility, we had posters and pamphlets that will be there and distributed, and we also have health talks and education sessions, and people who require services would be directed to where services would be provided, and we had what we can call hub and spoke model, where we would have a hub that is able to provide services there. If you look at the number of facilities that Molly was talking about, those are the hubs. But we also have outreaches to some of the satellite facilities around and be able to provide education there and recruit women from there and refer them to the hub for services, and we are hoping after the pandemic we will be able to even move around in those satellite facilities and be able to provide screening and treatment services at the same time. Yes.
Great, thank you. Molly, would you like to add any additional comments around demand creation activities?
Yeah, my colleague can shed some light on that.
Oh, my name is Peto. Good afternoon, good morning. When it comes to the improved HPV coverage, HPV vaccine immunization, we looked at the Ministry of Health has the program, expanded program on immunizations. So we just channeled the HPV vaccination to that program, and then we still have the school health. And when we started the HPV vaccination, we realized that it has really improved the school health that is based at the schools, but we still have a challenge in reaching the out-of-school girls for the vaccination. And demand creation, we're doing it through the social media, through radio, through television, and times when we have the campaigns, we do the, what do you call it? We have the speaker the PA system that we announce in the community that we are going to be there the following day. We announce through the radio, and the district that we are going to do the campaign, we announce 2 or a week before we start the campaign for screening. Thank you, over to you.
Great, thank you for those details. We are coming up on at the top of the hour, so I'm going to go ahead and wrap up the session this afternoon. I want to thank you again, my colleagues from Jphiego and from the Ministry of Health and Wellness. We very much appreciate your insights. We will have this video recording, this recording available on our website. Please do reach out, and if we can connect you with any of our speakers today, we're happy to do that from our side. So again, thank you all so much for joining, and we'll see you again, hear from you again at our next session. Thank you again. Take care.
Thank you.
Bye.
Bye-bye.
We are top of the hour.